Hello and welcome to our review of the lupus literature from February. We're going to be recording these podcasts for you every month, so you'll always be able to keep up to date on the latest literature and expert opinions. I'm Ed Vital, I'm the chair of the Lupus Forum at the University of Leeds in the UK, and I'm joined today by Professor Maria Dall'Era, who's a professor of medicine and chief of the Division of Rheumatology at the University of California in San Francisco, USA. But welcome, Maria.
Thank you, Ed. It's so great to be here.
Yeah, great to see you again. So today we've got three key papers from February that we've chosen to cover. And I had a look at the first one of these, which I thought was really interesting. This is a paper about a clinical trial about RNase therapy in SLE. And what I thought interesting here is just exactly how this drug works, because lupus is quite largely an innate immune disease in which your self-nucleic acids get treated as an antigen. And that happens via these nucleic acid sensors, whose normal function is meant to be to detect viruses, detecting your own nucleic acids. And the reason that happened could be a couple of reasons. It could be because maybe those sensors are a bit oversensitive. That's been reported. Or it could also be because these nucleic acids are sort of in the wrong place. Instead of being in the cell nucleus where they're meant to be, they're sort of out in the open where they can be detected as antigens. For example, if there's cell damage due to UV light in the skin, and especially if then when cells damaged, it doesn't get cleared properly. So the idea of this therapy was, instead of suppressing the immune system by inhibiting the function of immune cells, why don't we just try and get rid of that antigen? In other words, free RNA. That's the idea of an RNase therapy. The other interesting thing that they did in this trial is that the way they tried to target the population, because we know that there are these we know that you can have antibodies against Rho, Smith RNP, RNP, Smith, and immune complexes that contain those antibodies kind of actually carry RNA in the circulation, basically deliver it to the immune system as an antigen. And those antibodies are really strongly associated with interferon signature, which is what you get when detecting nucleic acids. So the idea here was that those patients might particularly benefit from this sort of approach. The patient with those antibodies might have a more RNA-driven disease. So in this trial, everybody had one of those antibodies, Rho52, Rho60, LA, U1-RNP, or the Smith RNP. It was also primarily a skin-focused study. So again, maybe because we know that interferon has such an important role in the skin and are so effective. So all the patients had skin disease with CLASI more than 10. About half of them had MSK disease as well. And the primary outcome was the CLASI score, numeric, as well as like 50% changes in CLASI, BICLA, SLEDAI, BILAG, etc. So this was a relatively small study for a phase 2A, 22 patients on placebo, 42 patients on the drug, which is called RSLV132, and it's an intravenous infusion. So what were the results? So baseline, there were, as often happens in the sort of smaller studies, there were a few imbalances seen. There were more males on the drug. They were more likely to have a less active clinical SLEDAI on drug, more prohibited medications used on placebo. There were also more African Americans on placebo, which can have a big impact on some of these antibodies and interferon status and things. And the SLEDAI scores overall were pretty low in this trial because skin doesn't affect your SLEDAI score that much on its own. So that first thing to note, there are a few little imbalances here. Overall, the primary they didn't power the study with statistical hypothesis testing, sort of descriptive statistics. But when you look at the change in CLASI, there wasn't really a difference between the drug and the placebo. However, as we always say, not meeting primary endpoints doesn't mean that drugs don't work in lupus trials. And when looking at some of the other endpoints, particularly in the patients who had more severe disease, a bigger difference was observed, and that's what's shown in the figure on the slide. So the patients who had SLEDAI of more than 9 or a CLASI of more than 21 seemed to show differences in SRI-4, BICLA, CLASI 50 responses. So it's one of those trials that's like promising that this might be worth more development. There's another interesting thing that I found, again, numbers are small, but seemed quite striking, which is the safety data. So like I said, this isn't really suppressing the immune system. It's more like removing an antigen. So that should be good. Well, the serious adverse event rate on placebo was 23%, and on RSLV 132 was 7%. And like we said, in a few other trials where often the actual interventions give less serious infections and things than being on placebo, because having active lupus and being on steroids is really bad. The other thing to notice, to comment about this one, is that this is their second trial, because they already did one in Sjögren's, which they reported a benefit, quite a fairly substantial benefit on fatigue, which is obviously a big unmet need in Sjögren's. So overall, I thought this was quite interesting, and I'll be interested in looking at what happens with it going forward. What did you think?
I agree, Ed. I thought this was very interesting phase 2A study. And I agree. I think what struck me initially was the unique mechanism of action and the fact that we are targeting an upstream mediator of the type 1 interferon pathway, just as you said, trying to get rid of that RNA antigenic load, right? And I think when you look at the landscape of targeted therapies coming through development in lupus, and then you look at the subgroup of therapies that are targeting the type 1 interferon pathway, there are many different molecules there. And this is another interesting way to impact that pathway. Again, very upstream. And it's as you said, it's highly encouraging in terms of the safety data. And to me, very striking that we can perhaps have an impact on that pathway without being immunosuppressive. And I also like the fact, as you pointed out, that they tried to enrich for participants in this trial that would most likely respond to this sort of therapy, right? So enriching for skin disease, patients had to have a certain CLASI to come into the trial. As you said, we know that cutaneous lupus is highly dependent on type 1 interferon for pathogenesis. And also making sure that participants had at least one of the autoantibodies to RNA binding proteins, as you said. I love the fact that they built that in to try to enrich for that population. Unfortunately, the primary endpoint was not met, but as you said, that doesn't mean that the drug doesn't work. And I think that especially in clinical trials in lupus, the post hoc analyses, the subgroup analyses, although we have to take them with a grain of salt, I think they can be very helpful for us to try to understand, are there some populations that may benefit? And of course, those analyses are exploratory, but they give us some confidence to move forward with drug development. So I agree with you. I think this is unique and exciting, and I look forward to seeing where this goes next.
Yeah, I think it just shows it's definitely subgrouping it and getting a target population seems to really make sense, but it just also shows how difficult it is, because I wouldn't have done what they did. I would have done exactly that. I said, yeah, let's focus on the skin, let's focus on the CLASI, let's focus on these antibody subtypes. But actually, the subgroup who did best was a little bit different.
Isn't that interesting? And
Yeah.
I agree. I think, you and I are involved, Ed, in trying to, in larger efforts to try to develop better outcome measures for lupus trials, right? And one of the thoughts is, should we be restricting populations and restricting trials to looking at organ-specific endpoints. And as you said, that's what they did, but it didn't work in this particular.
Not in exactly how they thought, but
yeah.
so I think that's one to watch in future development, really. Should we go on to the next paper?
Sure. Great. So I will take this one. So this paper is a nice paper that describes a new initiative that was taken on by the American College of Rheumatology to develop ACR endorsed quality measures for lupus. And this study here, or this initiative, was funded by the Centers for Disease Control and Prevention. And again, to develop quality measures in patient-reported outcomes that can be used in clinical practice. And what I liked about this initiative was it was highly systematic. They brought together experts in lupus clinical care, PROs, methodology, and then importantly, patients living with lupus were directly involved in this entire process, which is incredibly important, especially given the fact that we're looking at patient-reported outcomes and health-related quality of life. Just to go through with you, it was a systematic process, 4 phases. The first phase was to conduct a systematic literature review to try to understand which domains of quality of life are most important to patients living with lupus, as well as physicians who take care of them. Second phase was to then identify specific PRO instruments that matched to those domains. Third phase was to look at feasibility and validity of the patient-reported outcomes. And the fourth was then to select them to be used as quality measures and to think about at what frequency should these PROs be performed in the clinic to meet certain quality metrics. So at the end of this systematic process, the end result was a consensus around 2 domains, and those were physical function and depression. And then you can see on the slide here the recommended instruments that mapped to the domains. So for example, for physical function, the recommended instrument was the PROMIS Physical Function 10A, or the computer adapted technology, the CAT structured interviews. Additionally, one could use the MDHAQ, which is the Multidisciplinary Health Assessment Questionnaire. And then for depression, the recommended instrument was the PHQ-8, but there also are additional instruments that were recommended as well if one did not want to use the PHQ-8. And then importantly, the recommendation was that to meet this metric of quality, these patient-reported outcomes for physical function and depression should be assessed at least annually in the clinic. And so I think that the overarching idea here is that patient-reported outcomes are important. And I think there's a lot of literature, as we know, showing that there's a discordance between how patients living with lupus perceive their disease activity and how physicians perceive disease activity. And how can we meet in the middle and make sure that our patients' voices are being listened to, because they're the most important, right? We have to make sure that what we're doing, the medications that we're using, are directly impacting the quality of life of the patients that we care of. So this is a way of making sure that we systematically can measure quality of life in the clinical setting and perhaps tie these to quality measures. And so I think it was a nice initiative, and it's a way for us to, I think, move forward with making sure that we address health-related quality of life in our patients with lupus. But I would love to hear your thoughts, Ed.
Well, the thing I was thinking is, one thing that is that the interesting thing is what they recommend is not necessarily what always happens in trials to date, isn't it?
Right.
So I remember there was an initiative led by Vibeke Strand a while back about like what patient-reported outcome measures should we be using, and there was quite an emphasis then on SF36 and Lupus Qual, but I think PROMIS is a bit newer, isn't it? And I just noticed that features here, and of course, should we be, it has been difficult for new therapies to demonstrate benefit on patient-reported quality of life. And are we using the right outcome measures? Was one thing I thought.
I agree completely. And I think that, when this initiative here tried to look at what outcome measures are feasible to do in the outpatient clinical setting.
Right.
And that's why, the PROMIS Physical Function 10A, it's a short form that we actually use in our clinic here at UCSF. Easy, it takes a couple seconds for a
Okay.
patient to complete. And then the PHQ-8 is also very easy. So I think that these are defined for what busy clinicians can do in the clinical setting. But you're absolutely right, Ed. We have to think more broadly about what are the most effective and appropriate PROs to be used in the clinical trial setting. And that is being looked at now as well in larger groups. And actually the PROMIS scales are gaining traction as well to be used in clinical trials. But you're right, we're not quite there yet, and we don't exactly know which ones we should be using in the clinical trial setting. But I agree with you, it's very important to try to understand that.
And the other thing, I think quite often when I look at some of these patient-reported outcome data, which is, it's always quite bad, isn't it, in lupus patients? And now that we start to see therapies where people are aiming for sort of higher hurdle endpoints, aren't they? So like the CAR-T trials, they're saying this is meant to be long-term remission, and trials are being done that target LLDAS, or there's a treat to target trial going on in Germany and things like that aren't just response, it's more like properly getting down to low. And of course, will those treatments actually improve all this stuff as well? Will we say the physician's very happy, the SLEDAI score is low, but will the patients, they always say, even when I'm well, I don't feel great. And I guess the reasons for that, some of it's due to disease activity, but I don't think it all is it? Some of it's just due to having a chronic disease you've had it for 10 years, it's changed your life. And there's no medicine in the world that can give you back what it took from you, isn't there?
Mm-hmm.
Yeah,
Mm-hmm.
I don't know. I suppose I'm just saying, I think it's important always to analyze why people feel that way, isn't it?
Absolutely, absolutely. And as you said, I think that when we talk about things like pain, fatigue, function, there are so many different aspects to what goes into those. And I agree with you that we can't expect that immune modulating therapies or anti-inflammatory therapies will necessarily be able to treat all of those other
Yeah.
manifestations, especially when there are other underlying kind of pathogenic pathways underlying those manifestations. I
Yeah.
agree with you.
Great. So should we go on to the last paper? So
Sure.
this one, I had a look at this one, and this is a big reanalysis of some trials. It's a simple message, but it was one that did need checking. So this is from the group of Yannis Parodis, who spent quite a lot of time reanalyzing data sets from the belimumab clinical trials, which is what he's done here. And I think so. Some years ago, a few of us reported cases of patients who we'd put on belimumab for the non-renal indications, who had then had flares of nephritis while they were on belimumab. So I noted, just the first few patients on belimumab that I've started, there were a few who had new nephritis, and I thought, didn't expect that. And then I found that there were a few people in Sweden who had the same thing, and we published our cases together saying, that's strange that we got these nephritis flares, and we were sort of thinking, well, is this just you'd expect it because these are people with active disease that's not responded very well to therapy, and they're probably, for me, they have to be on double-stranded DNA positive or low complement as well. So, that's a population of people who are going to get a lot of nephritis flares. It's just natural, it's going to happen. Always there's some weird paradoxical effect going on that we didn't really know. So that's been answered basically here. So what they did was they pulled together 4 different studies, which had 3,225 patients all together on either belimumab or placebo to look at renal flares. There were 192 patients who got a renal flare during follow-up, which is about 6% of of the patients. So there it is, that's the rate. The rate of renal flares was lower on belimumab than it was on placebo. So about a 40% reduction in risk. But it does not appear to be like some weirdly induced by the drug paradox thing. Belimumab did somewhat prevent them. And then what they've also done here is they looked at what were the predictors of renal flares, and essentially, and so there are lots of things that were very different in univariate analyses, and what's on the slide are adjusted models where they've adjusted for the different predictors, and the independent predictors of flares appear to be having previous nephritis, not unexpected, having raised double-stranded DNA or low C3, yeah, not unexpected. There were Smith antibodies were only predictive in the patients on placebo, and anti-ribosomal P antibodies were only predictive in the patients on belimumab. I don't know why that is, but overall, it did suggest that the usual things that predict renal flares do predict renal flares. So I guess the message from this paper is, nephritis flares might occur in these people. You've got active disease, they're serologically active. If they haven't had nephritis yet, some of them will get it over time. The belimumab lowers the risk somewhat. The only thing I was left thinking, though, was that although it's reducing risk by about 40%, it didn't prevent all the nephritis flares. There was still enough occurred. So you can still get a nephritis flare. And it did also make me wonder, like, here in the UK, we use rituximab more as our most common biologic. So I just started thinking, how often do I see a nephritis flare in a patient who started rituximab for another reason? I'm not sure, actually. I wasn't really thinking about it, but maybe I need to look at the data to check my own bias on that. But it isn't, how much being aware of worsening as well as improvement is important. What do you think?
I agree. I think overall, the data are reassuring. I think, as you said, this is a nice kind of answer to the anecdotes and important data that you've published, because I remember reading your work, and there's a concern, and so I think these data were reassuring. But you're absolutely right that there's no slam dunk here, and that even our patients who are being treated with belimumab are, there is a certain proportion that are going to be at risk for having LN flares. And it's very interesting, and it makes us think about, well, what is the mechanism of the LN flare in that particular patient who's already on belimumab?
Yeah.
It just gets to, again, the immunophenotyping that we need to do better. And actually, interesting, I have to just say that I do have an N of 1 of a patient who we were treating, this is a few years ago, with off-label rituximab for extra-renal disease, had never had LN before, and developed new onset LN while on rituximab. But I only have one patient, and she was a 39-year-old woman of African ancestry. Very interesting, but only that one patient ever in my career. But it was striking to me, and I would have loved to have sent her your sent you her specimens, Ed, because you've studied this and to understand what was happening in her blood.
I mean, you've got to have your eyes open for these things, haven't you?
Yeah.
Lupus is full of surprises, and also rheumatology generally is full of drugs that had unexpected effects, like anti-TNF triggering psoriasis when it also psoriasis, and strange things like that are observed. So it's just you have to have your eyes open to these things. Lupus immunology is complex.
Yes.
Just because you block B cells doesn't mean you've undone everything. In my Mike Ehrenstein has a theory that might explain your patient. Actually, I think. I'm thinking aloud here, but because his report, he did the rituximab belimumab combination trial, beat lupus.
Yes.
And the motivation for that trial was that he looked at lots of the UCL patients who'd had multiple cycles of rituximab. When they get rituximab, the BAFF level goes very high.
Yes.
No B cells around. And he noticed that when they were relapsing, at the end of each cycle of rituximab, when they come up to the next one, the double-stranded DNA antibody titer was getting higher and higher and higher.
Uh-huh.
I thought that what actually maybe when you deplete B cells, because the BAF's so high, you kind of maybe sort of select autoreactive B cells for survival. So if as long as you keep depleting them, you'll be okay. But if you sort of have these breaks in treatment, then you might
Yeah.
actually that was his theory and the motivation for the trial. So maybe that's why.
Maybe that's why. Very interesting.
So that's the end of our 3 papers for this month. So thanks for joining, Maria. It's always good to have your thoughts on these developments.
Thank you, Ed. I think this discussion is always so stimulating, and it's a lot of fun for me. And I always learn a lot just from having these discussions. So thank you.
Me too. Yeah. And thanks everyone for listening. So you can find, as always, the full slide decks for each of these papers on lupus-forum.com. It's free to access always, and all the content is free to download. So don't forget to register for updates on the Lupus Forum, and then you'll get email updates when new content becomes available. And you can also follow us on Lupus Forum, or one word, on Twitter and LinkedIn. Thanks again, and see you next time.
Thank you.